Good evening, everybody, and welcome to HMRI, albeit virtually tonight, and to this seminar on healthy aging, where some of our researchers will talk about some of the great work that goes on here. So I'm Tom Wally, I'm Director of HMRI here. And before we start, I'd like to acknowledge the traditional owners of the land on which we meet, the Awabakal and Worimi Nations, and to pay my sincere respects to elders past, present, and future. So, thank you for joining us tonight. We're expecting around 250 people to link in. Looking forward to hoping all those connections work in the way they're supposed to. And I hope others will catch up on us later, because we're recording this and making it available on our website tomorrow. So I hope all of you are staying well. It's been an extraordinarily difficult time, and of course it's not over yet. We don't quite know what's going to happen in regard to the pandemic locally over the course of the next week or two, or even the next couple of days. So we'll have to keep our fingers crossed and look after ourselves and follow standard advice around hygiene and social distancing. So the health and well-being of the community are at the heart of everything we do here in HMRI. And during the current situation, we've been working hard in research in lots of areas, including in relation to COVID, with our colleagues in the health district and in the university, and indeed our colleagues all around the world. Medical research seems to be the best option for us to get out of this current situation in one form or another. So if you want to learn more about what we're doing in relation to COVID, you can find a particular link on our website that will take you to the relevant page. So our research is deeply connected to the community, and everything we do is to promote health within the community. And our researchers use all kinds of sophisticated techniques to prevent, diagnose, and treat diseases. And tonight we've got an opportunity to talk a little bit about how particular aspects of our research can make a big contribution towards health and well-being. And tonight I'm going to introduce two of our leading researchers in the area of healthy aging. That's Professor Julie Byles and Professor Kichu Nair. So Julie and Kichu have spent years collaborating with one another. So rather than have them stand up here individually and present, we thought we'd try something a little bit novel and perhaps have them sitting at a fireside. Now, there isn't a fireside here, because if there was, we'd have all the fire alarms going off and we'd have the health and safety people running around like lunatics. So we've avoided that, but pretend there's a fire here and you're in for an interesting conversation with our two presenters tonight. So they're going to share some of the research findings they've produced, which might help us all to age well. We're going to reserve about 15 minutes at the end to answer questions, so please send your questions in and we'll pick them up later on. And we'll have about 30 minutes or so to hear from Julie and Kichu about the kind of work they're doing. So let me introduce them individually. So Julie would like us to think of aging as a success. And it is, because of course, when everybody died young, aging wasn't an issue. And the fact that we have to think about aging nowadays is a remarkable tribute to how society and medicine has actually improved life expectancies. But that brings its own problems with us, as we're all aware. But we can do something about all of those to live better at every age. So Julie's key questions are around what kind of health services are available to people, how we access those services, and how those services can be optimized for the greatest benefit for people. Julie is co-director of the HMRI Public Health Research Programme and also the director of a priority research centre in the University of Newcastle for Gender, Health and Ageing. She's also the director of the Australian Longitudinal Study on Women's Health. I don't know if Julie plans to talk about that, but I hope she will later on during the course of the presentation. So Julie is nationally and internationally recognised for expertise in areas of contributions to public health and women's health, and for exceptional leadership and academic excellence over many years. Some of you who are long-time HMRI devotees may even recognise that Julie was once upon a time our Researcher of the Year, but that was in 2015, so you'd have to have a long memory. So it's also my pleasure to introduce Professor Kichu Nair. And Kichu has a focus on patient-centred medical care. He's had a lifelong interest in medicine and old age, and he's a highly respected clinician, researcher, and teacher. And his expertise has led to has been acknowledged, for instance, in his award of a member of the Order of Australia. So Kichu has pioneered new approaches to aged care for hospitalised elderly. The Maggie project has improved the quality of care for older people in hospital care and has been rolled out to many centres across New South Wales. And recently, in 2019, Kichu was awarded a large grant of over $500,000 from the Australian Research Council, specifically to address the topic of taking action, increasing advanced personal planning by older adults. And maybe Kichu's going to talk a little bit about that tonight as well. So Kichu is Professor of Medicine and Deputy Dean of Clinical Affairs at the University of Newcastle and Director of the Centre for Medical Professional Development within the Hunter New England district, reflecting his particular interests around medical education. So I'm going to hand over to our fireside duo and let them take it away, and we'll join you again after they've spoken.
Hi everybody. Kichu and I tonight we're going to be talking about looking forward to healthy ageing, because healthy ageing has a past, present and a future. We're going to talk about some of the things that you can do now and in the future to plan so that you can age well. So Kichu, just going to start talking about life expectancy, because it's been increasing over the last century, and a lot of people know that, and it is great triumph, and as Tom said, ageing is a success. But one of the problems we have when people talk about life expectancy, and you and I talk about it a lot, is that it leads to two misconceptions. One is that the increase in life expectancy has occurred because you get to 80 or 70 or 80 and suddenly people have tacked on some extra years onto your life. But that's not true. The years are actually tacked on at the beginning, not the end, so we'll talk about that. And the other misconception is that if you've reached your life expectancy, that's it. But in fact, we know that people live well beyond the life expectancy, because that's the average for the population. So much of the population is going to live well beyond that. So in this graph, we can actually see how life expectancy at birth has increased steeply over the first half of last century. So that's the blue line there and the green line there. But the other two lines, the red line and the blue line, that's life expectancy at age 65. So you can see it's higher, but hasn't increased as much as life expectancy at birth. And that's because most of the increase in life expectancy has been due to reductions in child and infant mortality and mortality of people at younger ages. So ageing is a success because it meant you live to your adult life. So someone born in 1926 had a life expectancy of about 60. Someone born in 1946 had a life expectancy of about 70, and someone born in 2016 has a life expectancy of about 80. But when somebody born in 1926 reached 65 years of age, which would have been back in 1991, they actually had a life expectancy then of 84.3 years, so a lot more than the 60 years they were predicted to have when they were born. And I have women involved in the longitudinal study in women's health who were born in 1926, and they're now 96. They're now in their 90s, and so they've definitely outlived the life expectancy of their birth cohort. And we asked them, why do you think you've lived so long? And they say, because I didn't die. And they're absolutely right. They didn't die as children, they didn't die as young adults, and the older you get, the longer you are likely to live. And if you're going to live long, then you want those years to be quality years, which is where healthy ageing comes in.
That's right. So what you're saying is, Julie, if you're going to look after a patient, don't ask how old are you, just ask how many years have you got to live. We always see this, 83-year-old person, when you look at them, you need to see how many years have they got to live now, and then plan accordingly. This is why President Kennedy said long time ago, our aim should be to add life to years and not years to life. So when you plan treatment, what we are looking is what's the quality of life they have, and they should be living healthy. For example, that slide there shows this is a plan A for everybody.
Yep.
Everybody wants a plan A. You want to live longer, and you don't have any disability, and then at the end, last few months, you get unwell and you'll die. But plan A does not happen. Often it's plan B. For example, that slide shows somebody is going well, suddenly they get something, some disastrous illness, or they have a fall, they fracture their bone, a femur, and then they may not go into trajectory A, they may stay in trajectory B, or if they're lucky and if we treat them properly, give them proper care, they may get back trajectory A and then live happily ever after. And unfortunately, there are some people who may be in trajectory C, which is a gradual decline. But what we are trying to say is everybody should be given an opportunity to get better after an acute illness, and they are able to then get back to better quality of life. So quality of life is very important, and if you ask older people, that's what they want. They want quality of life.
Yeah, and so the World Health Organization has started to redefine what's meant by healthy aging, and it's not just about having no diseases and no disability, but it's about building and maintaining for as long as possible the functional ability that enables people to be and to do the things they have reason to value. So it's what's important to them, and we'll talk about that a bit more. The only other thing I'd say about this graph that's come out of it's a conceptual graph, it's a theoretical model, but when we actually apply that to our data for women in the longitudinal study on women's health, two things. One is not everybody starts from the same point. So actually, the start of that graph, the lines don't all start at the same point. So some people actually go into older age with more disability and more needs. And some people continue on for a very long time with quite a high level of disability and quite a high level of need, but they can be supported and they can still have quality of life. So I said that healthy ageing has a past, present and future. So it's always really important to take a lifelong view of health. So how we get older doesn't start when we're 50 or 60 or 70. It starts when we're in utero. It starts when our mothers are pregnant, and in fact it even starts before then, because it's about how healthy our mothers and fathers are, and it goes back generations. But in pregnancy and childhood, we're wanting to make sure that people get the best start in life. We want to build those resources for strong, healthy humans. So maternal nutrition is important, early childhood education is important, building up your immunity, getting your vaccinations, all of that's important in childhood. It's going to be a little bit determined by some of the things around you, like how much advantage your parents have, the educational facilities that you're able to attend, what the home environment is like. And a lot of that's socially determinant. So we talk about social determinants of health. In mid-age, as adults, our job is to reduce damage. So, we want to avoid toxins like cigarette smoke or pollutions. We want to improve our antioxidants through good nutrition. We want to exercise and keep our strength, and we want to be able to prevent disease as much as we possibly can. But there's some other things that can get in the way of that. Again, our social circumstances, our work, our occupation, our relationships, and the physical environment around us. Then in older age, we want to minimise disease, because many of us will have developed disease in older age, but we can do a lot to avert the consequences of disease. We want to protect against the increasing demands on us, and we want to do things that compensate for loss of capacity, so wearing glasses, hearing aids, that sort of thing. And access to those things can be dependent on your financial and social resources and the social and physical environment around you. So social determinants and environmental supports are as important as everything else that's going on in the human body.
So we can talk now about health promotion in old age, Julie. One of the things is, we should be eating healthy, and there's also some evidence now that by calorie restriction, you tend to live longer. There are a lot of that's intermittent fasting has some beneficial effect in prolonging healthy aging. And we also know if you have a healthy weight, you're less likely to have back pain and osteoarthritis of the knee. So healthy weight and healthy eating is a must, and we should be promoting that. And then hydration, again, we often see older people, they may have increased frequency of urination at night time, they don't drink, so their kidneys can be affected by that. And again, we know that if you ask older people what's a major worry you have, it's always constipation. So if you have a healthy diet, the right diet, you don't have that, you can avoid that. And oral health is a major issue. If you ask our dental colleagues and say, that's something which we need to be looking after, and maybe we need to promote oral health more than what we do now. Alcohol, again, very debatable issue, but I think moderation is okay. And smoking, fortunately we see now a cohort of people who don't smoke. I think the current generation is aware of the risk of smoking, and I think we are seeing a cohort of people with less smoking, therefore better cardiovascular and respiratory health. Physical activity, we know that, unless you do exercise and you keep your joints active, that's good for your joints, good for your muscles, and it's good for your cardiovascular health. So I think we need to promote that. Social activity, again, older people want to talk to other people. And I think a lot of them, especially in this COVID times, is very, very challenging. They lose the social interaction. And we also know if you have social interaction, your risk of dementia can be diminished. So I think that's important. And also that will promote your mental health. And we also know if you have an active brain, it's almost like saying if you don't use it, you lose it. So if you are using your brain, whether it be reading the newspaper and trying to recall what you read, or doing your crosswords, or whatever you enjoy doing, and you need to keep the brain active as well as your body active. We also know by exercising, physically, it also improves your blood supply to the brain. That's good for you. Driving is a very major issue, very emotive issue, very legal issue, because we know for every kilometer driven, older people may cause minor accidents. That may be because when they get older, their reflexes are slowing down. Some of them have undiagnosed or undetected memory problems. If they are in an unfamiliar situation or a roundabout, they can get disoriented and get confused. So while driving is important for the independence, we need to see whether them driving is going to create issues for them or the public or their own families. I think we will talk about vaccination later on, because a lot of current older people have never had primary vaccination when they are growing up. So we'll talk about that a bit later when we talk about our health promotion and health assessment. And medication is a big ticket item. I think we can talk for an hour about medication in older people and what it causes. So yeah, I think we'll cover those as we go.
We will talk about medication specifically, but something you said about the weight and the caloric restriction. So I think it's important to think about what life stage you're at, because when we're younger, we need to keep a little bit thinner, but when we're older, it's actually helpful to have a little bit of extra weight, because if you're too thin when you're older, that's not necessarily a good sign, and you need a little bit more resources on there. And older people, when they lose weight, they often don't lose the fat, they lose the muscle. So we want to keep the calories up to older people so they don't consume their muscle.
We always talk about osteoporosis.
Yes.
We don't talk about sarcopenia, which is loss of muscle mass. If you put an older person in bed rest in hospital, after about 10 days they can't get up and walk.
They're weak.
Even when you look at the evidence behind bed rest, there's hardly any evidence. Older people should not be.
And don't stay in your chair. Get up.
Get
Get up and down. Work your quads. So We actually put together a cookbook. It's called Recipes for Life. It's available from the Department of Veterans Affairs website because they funded us to do this. But we worked on this with older people from the Return Services League and with students from the university, dietitian students and design students. And it actually covers, it has recipes in there, which are designed to be simple for, few ingredients and few steps if you're cooking for one or two. But it also has a lot of health promotion material in there about the things Kichu's discussed. So if you want that, you can download it from the internet by Googling Cooking for One or Two Department of Veterans Affairs, and you'll find that's available there as a PDF. So just talking a bit more about, you said how long do people have to live, and that's something you asked for. So in the longitudinal study on women's health, and also working with we actually worked with some people in Perth who had data on men as well, but I'm showing you the data from women here. We actually thought, let's have a look at that. Let's look at the probability that someone who's in their 70s might be alive still in 10 years' time. And we just based it in terms of their health, some of the fairly basic health risks like body mass index, so the healthy weight, the overweight, the obese. You talked about alcohol, so we had a look at how much alcohol they drink. We looked at whether they were smokers or not, and how active they were. So actually, the best probability of being alive in 10 years' time was if you were healthy weight, if you were physically active, if you were drinking a little bit of alcohol, because there's an interesting relationship between alcohol and health that all of the studies show that a little bit is okay. However, it may be that the people who don't drink are already sick. So the little bit there, we would not necessarily getting you to take up alcohol, but drinking in moderation and not in excess is important. And also quitting smoking. So you'll have the story about, the 90-year-old aunt who's been smoking cigarettes all her life and never had a day sick. But in fact, our data show that 96-year-old aunt will have a shorter life expectancy than the one that doesn't smoke. So those things are important, but it comes back to that thing about how long have people got to live, and thinking that someone who's 70 actually has a very high probability of living till they're 80 and a very high probability of living till they're 90. So don't write people off just because of their age.
Okay. This slide shows the burden of illness, chronic illness in older people. Maybe it's starting from the midlife. The one on the left is about men and the other one is women. For example, if you are 45, 54, most men, I think the chronic illness would be back pain. And then because of smoking, COPD is very common when they're in the 60s and 70s, and then dementia when they're in the 80s. So in fact, if you look at the burden of dementia in the world now, there are something like 50 million people with dementia worldwide. We only have 37 million people with HIV disease. So dementia does not get the same mileage as other chronic illness.
Yeah.
And again, we know somebody has dementia, it affects them, their families, and the society. So it's a big ticket item, if you ask me. Whereas women, it's a back pain, osteoarthritis. Again, we said about if you control your weight, it's good for your knee joints. And then when they become, in the 70s, it becomes dementia again. So dementia is a major item for older people. Again, men get ischemic heart disease and cardiovascular disease a bit earlier than men because maybe the estrogen is protective. And then as they also catch up as we go. So basically that slide shows what's a non-fatal disease and how it is burdensome for older people. So a lot of these things can be minimized or prevented by doing the right thing.
Definitely, a lot of them are preventable and a lot of them are manageable.
Yeah.
And the other thing I think that's really important about that slide, you'll see that cancer does appear on there, prostate cancer for men, but otherwise cancer doesn't have a big ticket in the non-fatal burden of disease Olympics that affect older people. But you will see things like diabetes, arthritis, tooth loss is in there as well. So we talked about oral health. So a lot of these conditions that you might think are a bit boring are actually really important for older people, but they're also really important because there's a lot we can do about them. A lot we can do to prevent them, but also a lot we can do to manage them to prevent the consequences of those conditions.
Right, yeah. So then we talked about some very important things for older people. I think this 5 M's, is put up by the Canadian Geriatric Society originally. It all started with M: mind, mobility, multimorbidity, medications, and what matters most to people. So it's a good way of looking at what's important for health promotion and managing health of older people. So we can expand on some of those in the next slides, Julie.
Yeah.
You want to add anything more there? Or?
No, I think that because if we take a disease model, I don't think you're capturing what's important to older people, because you don't get one disease, you get many.
Yeah.
So
Yeah,
that's the multimorbidity.
Yeah. So first one is the mind. So we know we discussed this, by actively engaging your mind, you're less likely to get dementia, or you can prevent it or minimize it. So there are 3 things about the mind in older people. It's a dementia, delirium, and depression. So all these things are important for older people. So basically, when we talk about dementia, we just not just talking about memory decline. Most older people have some slowing of memory. They may not be able to recall names sometimes. They may not be able to recall few things, but they manage. So that's only minimal cognitive impairment. When you say somebody has dementia, what we are talking is they also have difficulty with activities of daily living. They may also have some behavioral problems. So a lot of people are mild cognitive impairment, but they manage fine. So when you say dementia, you have that A, B, and C. That's activities of daily living, behavioral disturbances, and cognitive impairment. A demented patient or patient with dementia may have all those 3 things. Delirium is another common thing. In fact, when you look at our own hospital here, something like 30 or 40% of people who are admitted to medical wards do have delirium. That's because any acute stress, by whether it be infection or a metabolic cause or a medication, can cause delirium. And then they come to hospital, we put them in a very strange environment, then you change their rooms almost daily, so they get disoriented. Even, as you mentioned earlier on, even a normal person can get disoriented in a different, difficult, challenging environment. So an older person with already some diminished cerebral reserve, they get any acute illness or metabolic stress, they get delirium. So it's very common, and even delirium is more common in the surgical ward or even intensive care unit. So we spend lots of dollars in managing people with delirium, and we also know delirium, the mortality of delirium, 30-day mortality of delirium is higher than 30-day mortality in myocardial infarction.
Yeah. It's a deadly condition.
Yeah.
It's a medical emergency that needs to be treated.
Because delirium often is the underlying cause is often underdiagnosed or undiagnosed. So then that causes mortality and morbidity. And then if somebody is delirious, they are more likely to fall down in the hospital and fracture something. So it is a big ticket item.
And it's very important to differentiate that from dementia. It's very important to know that this is an acute change in that person's...
Exactly. And it's a very common issue in hospitalized people. And we tend to, it can be prevented. That's the main thing. There are lots of studies suggesting that if you make the room friendly for them, have proper lighting, if there's somebody, they're familiar with their families around them, they bring the family photos and keep in the room, orient them with the clock, those calendar, all those things are helpful, and reduce the delirium incidence and also reduce the length of delirium. So it's a lot can be done.
And even simple things like constipation or being dehydrated or having a urinary tract infection can do that to somebody. So that's why we've got to keep all that sort of really bread and butter things about our bodies running well.
Yeah. And again, the third D would be depression. Again, depression often, when you look at, when older people have multiple medical conditions, they're not as independent as they were before, it's not surprising they get depressed. So it's again underdiagnosed and undertreated. So
and again, important differentiation between depression and dementia, because you might think they have dementia, but they're depressed.
Yeah.
So that's important.
That's why it's called sometimes pseudo dementia.
Yes.
Yeah.
So that brings us to dementia, because I think that's something everybody's very interested in. It's important to prevent, it's important to manage well, and it's important to care for people who have dementia. But and we've been talking about things you can do to for now and the future to look forward to healthy aging. And so if you look at the risk factors for dementia, they're actually very similar to the risk factors for a lot of other conditions. So if you do something for your dementia risk, you're probably doing something for all of your other risks. But this is a really nice paper that was published in The Lancet a few years ago. They've looked at what factors contribute to dementia, not just how strong the risk is, but how common these factors are in the community as well. And they've put them in terms of the life course. So what happens early in life, what happens in the middle, what happens later. So you've got things like less education, which is something that happens early, obviously. Hypertension, so paying attention to your blood pressure and using your blood pressure medications if they've been prescribed, but also keeping your blood pressure down by exercise and those sorts of things. Hearing impairment is actually a midlife factor. So if you've got a hearing difficulty, go and see the audiologist and get the hearing aids, because that may actually alter your dementia risk. Smoking's an issue, obesity is an issue, depression's an issue, physical inactivity, diabetes, and infrequent social contact. So these are the things we've been talking about. And in recent years, they've added 3 new risk factors: excessive alcohol, head injury, and air pollution. Because remember, I said it's not just about what's happening to you as an individual, it's the environment around you that's important as well. So actually, hearing is actually a very interesting issue for older age, because a lot of people do get, we call it presbyocusis, but they get the hearing loss as they get older. And so, the whole hard of hearing thing. And then people won't necessarily use their hearing aids. They're a little bit embarrassed about having their aids in. They keep them in the drawer, and they actually don't work if you leave your hearing aids in the drawer. Got to put them in your ears. But we actually did some research to have a look at how hearing was relating to other aspects of quality of life, and people with hearing difficulty actually had more falls, and they had worse physical health and worse mental health. So really, if you have some issues with hearing, we encourage you to get that looked at, find out what the problem is. There might be an underlying problem, or use the devices, the supportive things in your environment to improve your hearing, because that's going to help your social interaction. Right. It's going to help all sorts of other things as well. And then the next thing we'd look at is this physical activity, physical functioning, and how that changes with age. So if you remember the nice graph that Kichu showed at the beginning, and I said we have our own data that is sort of like the reality data, and that people come in on different trajectories to begin with, and then they have a different slope of change. And so in our study of women, following them from their 70s through to their 80s, almost their 90s, we found that 14% of the women actually did have trajectory A. So that was good, 14%. And then there was about a third who had maintained fairly good levels of physical functioning over all that time. Another third or so who started off quite high, but their trajectories went downhill after a while. And then there was 15% who actually lived a long time, but with quite a lot of need and disability. So we had a look at the factors that might keep you in trajectory, the purple trajectory up the top there, where we'd all like to be, where we can run and lift heavy objects and do things. Oh, you don't know if you necessarily want to lift the heavy objects, but you can walk, you can climb stairs, and you can do all of that, compared to someone who might have difficulty moving around their own house. And again, education was important, exercise was important, being in a healthy weight range, not overweight and not obese, was important, not being a smoker was important. Having any of these diseases, arthritis, stroke, osteoporosis, heart disease, diabetes, hypertension, bronchitis or asthma were important. But if you had any one of those diseases and you had another disease, that increased your chances of being in that poorer health group again. So, these are sorts of things that might make a difference to whether you're in trajectory A or you're in one of the less favourable trajectories.
Okay, this is about multimorbidity. We said one of the M is multimorbidity. And if you ask people, there's a saying that at the moment in 2020, the common condition we all look after in hospitals or general practice or community would be multimorbidity. There's nobody with one single disease. So, for example, if you are 70, people think you have at least 3 conditions or 3 diseases. If you have 3 diseases, you are taking at least 5 medications. So then, multimorbidity brings polypharmacy. We'll talk about it in a minute or so. So this is a slide from the Australian longitudinal study on women. And again, it shows most people have multimorbidity.
And the older you get, the more you have.
More, yeah. So, in that study, by the age of 85, you have 70% of arthritis, 40% heart disease, diabetes, asthma, hypertension, stroke, and dementia. So there's no person now, very unusual to see an older person with just one disease. All of them have more than 3 or 4 or 5 diseases. So when you manage them, you have to be very proactive, and you have to think of the medication and what's important for them. Yeah.
Because sometimes the management of those diseases might compete with each other,
Exactly.
and one might complicate the other.
Yeah.
So one of the things we've looked at, Kichu, is about healthy life expectancy. So we talked about life expectancy at the beginning, and you said it's not the years in your life, it's the life in your years. And actually, with one of my students who's here in the audience with today, Befficado, we've been looking at how diabetes might affect healthy life expectancy. And what we found is that while diabetes is very common, and it's increasingly common with age. And so, around about 21% of our women in their 80s have diabetes. We're also finding that it's more common in successive cohorts. So the next cohort coming up in their 70s, a lot of them have got diabetes as well. But the good news is that diabetes can be well managed. And so whilst diabetes was affecting the women's healthy life expectancy, and the ones with diabetes had a lower healthy life expectancy than the ones without diabetes, one of the important things that Befficado found was it wasn't just the diabetes that was making a difference. It was some of the other things we've been talking about. So education, the risk factors, the BMI, and the comorbidity. So it's not just having one disease, it's having the other diseases that you have. It's also your life circumstances. And part of that's tied up in how well you can manage that diabetes. So if you have diabetes, it's very important to monitor how the glucose control, and very important to make sure the medications are adjusted to be right, and that your lifestyle is the best it possibly can be to be the healthiest person with diabetes that you can be. So medications then become really important in managing disease.
So one of the big M's is medication. As we mentioned, we all treating people with multimorbidity, so they're more likely to take more than one medication. There's a definition of polypharmacy. Polypharmacy, or taking multiple drugs, usually is defined as more than 5 medications per person. But if you don't need any medication, if you're taking one, that itself is polypharmacy too. There's a dictum, we all say we give a pill for an ill. So what we are thinking is there's an ill for a pill too. We don't talk about it. So every drug you take have side effects. If you're taking 2 drugs, they interact. If you take 3 drugs, they all interact with each other. You're taking 5 drugs, you have more interaction. So this slide shows, that there are a few issues we need to highlight. These are frail, older people, that the median number of tablets, some of them were taking 12 to 14. Mind-boggling. Then there's a big push for de-prescribing now. If you see a patient, you have to see why they are taking that medication. Do they need it? If this new symptom is side effect. We have to think about that. So that's a very common issue. In fact, we think 25% of older people admitted to our hospitals, when you look at their medications, they have medication-related side effects, which is often underdiagnosed. So we need to spend more time looking at the medication and see why they're taking, and is it necessary, is it causing side effects. The other thing also is, a lot of people say, I've been taking this blood pressure for last 25 years. But your body has changed in the last 25 years. Your physiology changes. When you get older, the way your body metabolizes your drugs, how it travels in the body, how it acts at the receptor sites. That's called pharmacokinetics, pharmacodynamics. They are different. So you need to fine-tune the treatment. So that's very, very important. Then there's the issue of under-medication, under-treatment. Good example is one of our research students is doing a big study on atrial fibrillation, which is common. 20% of older women have atrial fibrillation. When you look, and the ideal treatment is anticoagulation, blood thinning tablets. And we also know the older you are, higher your risk of getting a stroke. So if you have atrial fibrillation, you're likely to get a stroke. So you need to be treated. In that study, something like 40% of people never got any proper treatment for atrial fibrillation. So under-treatment also is common. The other big issue would be people coming with acute stroke or an acute heart attack. You need a clot-busting drug or thrombolytic treatment.
Straight away.
Well, straight away. And they don't get it, or they are under-treated. So under-treatment is common, polypharmacy is common. So medication is a big ticket item, and we need to look at it. And we know, one of the studies we published in Age and Aging is about sleeping tablets. Older people know because of the physiology, altered physiology, sleep pattern, lack of exercise again, or maybe too much of drinking alcohol again, REM sleep goes down. So they don't sleep properly. So they take benzodiazepines, sleeping tablets, and they're more likely to fall down there. Then we went and asked them 2 years later, are you sleeping any better? They said no. Is your quality of life any better? Quality of life, SF36 was worse. So sleeping tablets does not do anything to you, only they're harmful.
And you get dependent on them, so they don't help the sleep at all.
They get confused too. So medication is a big ticket item. A lot of people are over-treated. Some people are under-treated. Drugs do interact, there are side effects. You need to review medication every time it's an older person.
But the good news is you can have a medication review funded through Medicare, and encourage people to have that. And the other thing that's funded through Medicare is the 75 plus health assessments, which we've been working on for a quarter of a century.
Yeah,
so,
that's right.
Yeah.
So this is, we did a randomized controlled trial of health visits by a trained healthcare worker at people's homes. So the trained health worker went to their home, spent a reasonable amount of time checking at various things, assessment, and found out that, yes, certainly that's beneficial. And subsequently after that, that's when the 75 health assessment item number came.
Yeah, we had a big influence on that, yes. You can go to Hansard in Parliament and you can see that, Kichu.
So again, patients were happy, or people were happy, and it's interesting too, healthcare workers are also happy too. For example, that's our healthcare worker who went to see a patient at home and they thought they were making some positive impact on the older person's life, and they were able to stay at home healthy. So that's very important.
That's right. And we've been continuing to evaluate how people are using those health assessments and the effect on people. So one of the things that during the health assessment, they look at your blood pressure, they look at your diabetes management, your pulse rate and rhythm to see if you have got the atrial fibrillation, what medications you're on, how you're managing with continence, do you wish to quit smoking, problems with feet, because that can be important for older people, your immunisation, and your assessment of your physical functioning. And so, you know, the sorts of problems we did find people have were problems with sleeping, not being able to climb the stairs, urine, problems with their feet, and a lot of people who hadn't had the vaccinations. So make sure your vaccinations are up to date. We've heard a lot about it this year with the influenza. But yes, so when we did the health assessments, we find lots of problems, but again, lots of problems that are amenable to prevention. Which brings us to our very last slide, which is about what matters most to people. And what matters most to people is the maintenance of abilities to keep doing the things they want to do. And so that's why rehabilitation is really important. If you've had a stroke or a fall, to get back on your feet and get going again. But also a concept of reablement. So being able to work towards doing the things that you want to do, even if you have to do them a bit differently. And I'll get onto my little bandwagon now about getting support. So if you need help, seek help and accept help. Because we've found from the women in our study that a little bit of help helps, and a lot of help helps even more. So we really encourage people to be proactive about seeking help and look to be able to get help to keep doing the things you want to do rather than getting help for the things you can't do. Advanced care planning, with Kichu has been talking about, and maintenance of quality of life. So we've been talking to women in their 90s about what they do, and quality of life is really important to them.
Advanced care planning is something which is not done properly. If an older person, if they want to look after the quality of life, they have to write it down. They need to discuss with the next of kin. They need to talk to your doctors and specialists and general practitioners. Unless you do all those things, it may not happen.
And need to review it.
Yeah, so I think it's very important for all the people who have advanced care planning and have all those things done. Otherwise, it doesn't work.
So we'll wrap up now, Kichu, because I think it's time for questions. But, you know, what's needed for healthy ageing, this comes from Help Age International, but a change in the way we think about older people. So let's get rid of our ageism, even our internalised ageism. Creation of the age-friendly environments to support people, alignment of the healthcare systems to the needs of older people, and the development of systems for long-term care. And so that we can keep doing the things we value for as long as possible.
Yeah, so somebody said, look, healthcare system should be judged by the way it treats older people. And this is why we piloted the Maggie program here, because the flow of an older person in the healthcare system is very, very suboptimal. It's not friendly to us older people. So, somebody said, if the system doesn't do what you want to do, you need to change the system.
So that's it. We hope you've enjoyed our fireside chat. Thank you very much. And it's good night from me, and it's good night from him.